All right, this next chapter is chapter 14, Normal and Abnormal Labor. We're going to start with an overview of what labor is all about. I want to first talk about uterine changes. The uterus is largely smooth muscle, and during pregnancy, it increases in size tremendously. Each individual myometrial cell hypertrophies 20 to 30 times. This represents a non-pregnant myometrial cell. This represents a pregnant myometrial cell. You know, the cardiologists think that the heart is a wonderful organ. The cardiologists have never heard of the uterus. The uterus in the non-pregnant state weighs about 60 grams, 2 ounces. At term, after you take out the fetus and you take out the placenta, it weighs 1,000 grams. After pregnancy, it goes back down. Next pregnancy, it goes back up. Do you know of any heart that does that? It's a marvelous organ. In terms of labor, we can view the uterus in 2 segments. The uterus has an upper segment and a lower segment, and there are specific and different changes that occur in both of these. The upper segment is the contractile one. That's the one that thickens. The lower segment is the area that thins, and this is the one which does not contract. This is a uterus of a patient that I opened up with a classical uterine incision, and you can see how thick the upper segment is with the white arrow, and notice how thin the lower segment is with the black arrow. Now this is a cute picture, but it has more than just cuteness. It has tremendous symbolic value, because for many, many months, the fetus is within the bag. The bag is the uterus. And it's only toward the end of the pregnancy that the opening to the bag opens up. And that is what happens in labor. And there are 2 processes. There is cervical effacement and there is cervical dilation. For most of the pregnancy, the uterus and cervix have a containment function. We want to keep the fetus in there until it is ready for extrauterine life. Most of the uterus, as we said, is smooth muscle. Most of the cervix is collagen. And when we look at the internal cervical os, about 75% of the tissue is collagen. When we look at the external os, 90%. So the uterus in the upper segment contracts. In the lower segment, it thins out. And this is what cervical effacement is all about. Here you can see a cervix which is dilated and is effaced, thinned out to where it has no length at all and hardly any thickness. Often we will refer to this as paper thin. The initial part of preparation for delivery is cervical softening and effacement. What happens is these collagen fibers, which are linked by these disulfide linkages, those disulfide linkages break and water comes in between, and instead of being soft, I should say, instead of being firm and hard, it becomes soft. One way that I like to describe this is the cervix changes from feeling like your nose, which is firm and long, to your lips, which are soft and thin. This is a process of effacement. Now here you can see a cervix which is long and which is thick. The external cervical os is here. As effacement occurs, notice how the cervix shortens. It is still wide. The internal os has now been pulled up to here. With further effacement, the internal os, which used to be down here, is now up here. And notice how the cervix has almost no length at all. Still hasn't dilated a whole lot. It is the effacement which is the initial change. This is an artist's diagram of what happens to the cervix during effacement. This is the internal os, this is the external os, and you notice there's a T-shaped. The next thing that happens is the internal os starts funneling, and here you can see a Y shape. As the effacement goes further, it becomes into a V shape, and the cervix has hardly any length anymore. And the last is it becomes a U, and the cervix is markedly thinned out here, and now it is ready to dilate. So we can think of the T, of the Y, of the V, and of the U, all cervical effacement. All right, let's next look at the cardinal movements of labor. The cardinal movements of labor have to do with the changes in the head of the fetus as it rotates internally, externally, flexes, and extends. In order to understand this, we need to look at the pelvis. And this is the pelvis, the bony pelvis. Here is the pelvic inlet. When you look at the pelvic inlet, you see that the narrowest is the AP, anterior-posterior dimension. The widest is the transverse. So the head, as the fetus comes down, is going to have to be entering the pelvis transversely. The mid-pelvis is limited by the ischial spines. These are the ischial spines. Now you notice that the mid-pelvis has different dimensions. The longest dimension is going to be anterior-posterior, and the narrowest dimension is transverse. So the fetus enters labor transverse and has to undergo internal rotation to pass through the mid-pelvis. So here is the fetus entering labor transverse. In order to go through the mid-pelvis, it has to rotate anterior-posterior. So what we will see is the changes as it moves through. Now these will occur as the head comes down. Engagement is a term that describes the descent of the head through the pelvis. As the head comes down, the forces of the uterine contractions bring about flexion of the head. So engagement, descent, and flexion occur simultaneously. Following this are the sequence which always must be followed. Internal rotation, which is followed by extension, which is followed by external rotation, which is followed by expulsion. And they could very well have on the USMLE2 exam a question where they ask you which of the following options is the correct order in the cardinal movements of labor. So the head, as you can see, is transverse. Notice the shoulders are anterior, posterior. As the internal rotation takes place, we see rotation from transverse to anterior-posterior. Notice the shoulders are coming now ready to enter into the pelvis as the head is moving through the mid-pelvis. The shoulders are now transversely. As the head is coming out of the mother's body, the shoulders are going to have to start moving from the pelvic inlet through the mid-pelvis. And so the shoulders are now going to rotate 90 degrees from transverse to anterior-posterior. And notice how that happens. As that is happening, notice the head externally is rotating from anterior-posterior to transverse again. So, simultaneously, engagement, descent, and flexion, followed by internal rotation, extension, external rotation, and then expulsion. So here we have the head transverse, ready to go through the pelvic inlet. You can see the head is flexed, the chin is against the chest. As the head is descending, notice it is internally rotating to anterior-posterior. The head then extends as it comes underneath the pubic symphysis. Once the head is out and the shoulders now need to rotate internally, the head rotates externally. So here we have before engagement, engagement, flexion, descent. We have descent and internal rotation. Notice the head is still flexed, the chin is against the chest. We now have complete internal rotation, and the head is going to start to extend. Here the head is extending. Notice the shoulders are transverse. The head is anterior-posterior. We then lift up the head to deliver the anterior shoulder. Then we move the head posteriorly. Here's a posterior shoulder. Ah, happy baby. All right, so remember the sequence. That's the end of overview of labor.